Okay, so hi everyone. Today we'll be talking about COPD once again with Dr. Andrew Lee. So the first question actually is more of an interesting question. I've noticed that there seems to have been a slight change in terms of the way COPDs are classified over the course of the years. There was first the pink puffer bloom bloater paradigm thinking, and in 2006 they brought in the FEV1s in terms of classifying COPD. At 2011, this table was very complicated because we had symptoms, we had exacerbations, we had FEV1, everything in one setting. And in 2017, I understand that the FEV1 was sort of dissociated from the scoring or in the classification system which guides management. What's the thinking that is going behind this?
Okay, so this all boils down to two main principles. One is that FEV1, the severity of FEV1 doesn't really correlate with symptoms.
Okay.
The second is that if you think, but it does have a prognostic value. I think the second and more important thing is that you must think of what the current regimen or what the current regimen of inhalers do we have available, and what their intent is. Most of the intent, if you look at the studies, are based on symptom control and reducing number of exacerbations, which is why people started shifting to this box. Maybe you can go back to the previous slide.
Or you want to go back to the previous?
The other one, yeah. Okay, this is fine. Okay, this is okay. Where you look at the initial one in 2011, where there's a box that looks at symptom control with FEV1 staging, and on the right side the yearly exacerbation, and you moved away in 2017 to remove the FEV1 staging component simply because it didn't correlate with symptoms. Sure. And what happened is that if you look at these boxes are supposed to enable you to know at this stage, this is probably the inhaler of choice. Because of the evidence behind it, you would give this inhaler to actually reduce exacerbation of symptoms. So that's how the choices have evolved.
Okay. Thank you. Okay, so we'll move on to a case scenario now. So Mr. Tan is a 60-year-old who was admitted for productive cough, fever, and some shortness of breath. X-ray showed some right lower zone infiltrates, and he was treated as for likely community-acquired pneumonia. On further history, he says that he's been getting progressively more breathless over the past year. He's a smoker of 40 pack years, and the X-ray also did look slightly hyperinflated. He's otherwise still able to continue his work as a taxi driver, but feels slightly bothered about this progressive breathlessness. So the first question, once again, when it comes to diagnostics, when should this patient get his spirometry, and how frequently should it be repeated once COPD is confirmed?
Okay, so the spirometry should always be done in a non-acute setting.
Okay.
So yeah, because one, they may not have the effort to do so because they're breathless. Number two, it may not be the true reflection of the actual baseline severity. So let them get recover, let them get better. If you're always concerned that this is COPD, you can always start the inhaler first and then come back to clinic 4 weeks later and then repeat spirometry. Okay, once you have confirmed the diagnosis, like I said in the asthma section, that it is advisable that you should do this on an annual basis. This is unlike asthma where we don't really do it regularly, but there may be a role if the patient actually has a low FEV1 with what sounds like chronic irreversible obstructive asthma, and then that would be another story altogether. Okay.
And the purpose for the yearly FEV1
is you want to see how fast does the FEV1 decline.
I see.
Now, if we know, I did say that FEV1 severity does not correlate with symptoms usually, but if you can imagine as your FEV1 decline, it also means that the small airway disease is getting worse. There's a loss of elastic recoil. There is emphysema being produced. Eventually, these patients become symptomatic. So one of the intents and purposes of the medications that you give is actually to reduce the rate of decline of FEV1.
Okay. Thank you. So we go back to our patient. The FEV1 over FVC is 0.65 with no reversibility with FEV1 of 53%. Let's have a quick word about treatment. I think the first question that I have is that there seems to be quite a lot of treatments listed here for COPD: smoking cessation, pharmacological therapy, pulmonary rehab, LTOT, etc. Which of these treatments actually have mortality benefits for our patients?
Okay, there are only 3 treatments that have mortality benefits COPD. Okay, 1, smoking cessation.
Yep.
2, LTOT for the subgroup of patients.
Okay.
Okay, which are PO2 of less than 55 or PO2 of less than 60 with concurrent pulmonary hypertension called pulmonary or secondary polycythemia. The
Okay.
third, which is in recent times that has been found, is a subgroup of patients with COPD with chronic hypercapnia of a PCO2 of more than, if I'm not mistaken, I think it's 53 or 53. And in this group of patients, if you give nocturnal NIV, there is some mortality benefit.
Okay, thank you. So we go back to our patients. I think likewise with asthma and maybe even more so with COPD, the thing that residents struggle with is really making sense of the options that we have. So on one hand, we have this table that tells us group A, group B, group C, group D. These are the options. Once again, we have our list of medications. But at the same time, there are so many different preparations for LAMA, LABA plus LAMA, ICS plus LABA, with different types of inhalers that you've also talked about. So going back to our patients, what exactly practically would you do for him?
Okay, so first of all, it's the same principles as for the choice of inhalers for asthmatic patients. You first want to ask what's the intent. So unlike asthma, where the intent is actually to reduce exacerbations, the intent in COPD patients for inhaler choice is actually to relieve symptoms. Think about it. If the patient with COPD has irreversible airway obstruction, you want to bronchodilate them so they feel a bit better. So your intent and purpose, first of all, is to relieve obstruction. So you know that in this case, your choices would be a LAMA or LABA first.
Okay.
Unlike, we will probably choose LAMA over LABA because sufficient studies have shown that LAMA is superior. So nowadays, we don't really have a isolated LABA inhaler. We don't really use that anymore.
Sure. Do we give short actings in very mild COPDs? Because I think
so that is a good point because yes, if you go and look at the guidelines, they will say that in group A you can give a short-acting bronchodilator. But more and more nowadays, we find that it is better for us personally. It is better to start a long-acting bronchodilator even in group A. The reason is because there are enough. Most of the patient, the FEV1 decline is at its steepest in group A and group B.
Okay.
Even though they are asymptomatic. So that's the reason why a lot of people start to advocate giving LAMAs from the outset.
I see.
Yeah. So nowadays rarely do we give short acting.
Okay. So you mentioned LAMAs usually for first line. So in terms of this table, I see you have tiotropium, you have glycopyrronium, you have
which comes to the second point of the device and the device type.
Yep.
The patient's comorbidities and ability to use the inhalers.
I see.
COPD patients are older.
Yep.
They have more comorbids. So therefore, you need to see whether can they coordinate. If not, maybe an aero chamber with possibly a respiratory mat will be required. Are they able to have a good inhaler, good inhaling technique, or do they have the strength to even form a good mouth seal? If not, maybe an aero chamber is also required, or MDI if necessary. In most of these cases, is the respiratory mat, the breathaler, or the ellipter, which we'll be choosing. Now, the choice between all three different, then there's of course this LABA-LAMA combination, which you use either group B or group C.
Yeah.
This is where the honest truth is that there is no big difference between all three, but in Singapore, because of financial cost, Anoro is the cheapest.
Anoro is the cheapest.
In fact, it may even be cheaper than some of your LAMAs. So some people may elect to just give Anoro straight off.
I see. Okay.
So that's why I go back to the same principles. Indication, device, patient's comorbidities, finances. Okay, understanding is important, but I think it's more predominant for the Symbicort and smart therapy issue that I do. Yeah, in COPD, it's usually a daily thing.
Okay. So maybe we do a practical deep dive into the LAMAs, right? So LAMAs wise, we have tiotropium, we have glycopyrronium, and we have umeclidinium. So in terms of so let's say this gentleman doesn't have very overt like RA kind of thing, the hand coordination is not too much a problem. He's, in terms of finances wise, he would rather something not too expensive, and he's still able to coordinate fairly well. Which LAMA would you give in this case for this gentleman?
Okay, again, I think this question is actually a little bit harder to answer simply because Um, uh, okay, first of all, I think the question really is cost, and it's really whether the what type of devices he has.
Mm.
Now, you ideally like to choose a device that is similar throughout.
Okay.
Look at the different devices that you have.
Yep.
You have a series that are just no, maybe you go back to that. The table is enough already.
Okay.
You have breeze haler, and then you have MDI. They have ellipta. So if you think about it, you want to give if you want to give everything that's ellipta, you want to give a noro with maybe a flute with maybe inhaled steroids. Okay. So, sorry. Let me rephrase that statement. Number one, we don't have handy healer anymore for tiotropium. It's no longer available in Singapore.
So it's Respimat or Tio, is
Yeah,
it?
it's only, yeah. So if you need an aero chamber, ideally you use the devices that have a Respimat.
Okay.
If the patient has good inhaler technique, okay, and is able to do a slow, deep breath, you can use the ellipta. Okay, particularly because Anoro is the cheapest, so people will go for that. Okay, there has been certain studies like the Flame trial which compared Serotype versus Altibro, and then there was some benefit with Altibro. So people initially had veered towards Altibro and using the Breeze Haler, where it's a little bit. The Breeze Haler is okay. Do you have a picture
of the inhalers?
Yes.
Do we have?
Yes, you have it there. Maybe you go down to yes, there it is, the Altibro one, and the yellow one.
Yellow.
You move,
yes.
Is a capsule. So the two little yellow buttons there, okay, you will have to put the difference between the two devices is that requires you to put in a capsule, whereas the Anoro at the bottom there, although you cannot see, there's actually a number there to tell you how many doses are left.
Okay, yep, I can see
that is actually very important, to help you to determine whether there's compliance. So that's why there are a lot of different. That's why the again I go back to the same 4 principles.
Yep.
If you cannot coordinate, you go use the Respimat and you can use the aero chamber. If not, usually we are now going towards using ellipta because we use Anoro, which is cheaper. But some people, if they prefer to use a capsule or they are used to it, then people will start going use the Breeze Haler Altibro.
Sure. Amongst the Lama, is the Incruse also cheaper compared to
no, not really.
Not really lah. So it's
Not
only
really.
Lama where Anoro is particularly in terms of price-wise favorable lah.
Yes, Anoro is actually the most favorite in the market right now.
Okay, whereas for the Lamas, the TO, the glycopyrronium,
Tio is a bit cheaper if I'm not mistaken.
Okay. Thank you. That's really helpful. Okay. So maybe we move on to this question that I have in terms of the group B, right? So some of these patients are on long-acting bronchodilators.
So I've mentioned it already in the earlier question. It's the same issue as group A. We would give a LAMA for the same reason.
When it's a LAMA and then they are like having acute exacerbations, they don't need a short acting with them lah.
Oh, they should. When you have group A and group B, right? Even we will usually give the LAMA. You will also give them a standby SABA to actually help relieve the symptoms if they have some answers. Okay,
so the long one would be LAMA, whereas the short acting one would be a like a Ventolin lah, rather than you won't give both of the same class, correct?
Correct, but some I think this one's physician preference. Some differ lah.
Okay, so you can theoretically give a SAMA and a LAMA, or that would
you
be
run an increased risk of ARU, BPH. That's the main concern, but generally, people give Ventolin.
Okay, sure, got it. So in terms of this, I think you did mention that some trials did show that LAMA was superior to LABA, and that's why we tend to favor LAMA over LABA. Is that correct? Okay, and okay, maybe this last question for patients who, okay, maybe the first question is when do you consider ICS for COPD patients? And the next question is if they end up on triple therapy, practically what do they end up on in terms of the devices?
I will follow this. I will go back to the same principle. So you try to use a device that is similar throughout as far as possible, although usually practically that's not possible. So it's usually a LABA-LAMA with an inhaled steroid.
Okay.
Okay, we use a LABA-LAMA as one inhaler, and then we use an inhaled steroid as the other. There has been studies of one dose triple therapy. It has shown some superiority. Right now, we only have it as samples, so not always used.
All on a single device.
Yeah.
Okay. And when do we consider ICS in patients with COPD? I'm not sure if you mentioned on my audio.
It goes to group D.
Okay.
But what the purpose of inhaled steroids in COPD is actually reduce exacerbations.
Okay. And do we usually stick to the eosinophil count?
That one's a controversial topic. Some people will say that if your eosinophil count is more than 300, they respond better to steroids.
Okay.
Go clinically.
Okay, sure. So practically, normally you start with a LAMA, then becomes a LABA-LAMA, and then if let's say they are still not very well controlled, then you would consider
inhaled steroids. But if you see that their eosinophil counts are high, 2 questions for yourself. Is this chronic asthma rather than COPD, of which they may respond better to inhaled steroids? Or is this a COPD with eosinophilia, which means that their response to inhaled steroids may be there and you can give a trial.
Okay, thank you. Okay, I think we've sort of covered this. Do you particularly take into account whether it's more dyspnea or exacerbations to determine the way you up-titrate your medicines?
Yes, which is the very reason why I said that you need the first principle of inhaler choices. What's the intent?
Okay, so you mentioned that ICS comes in more for exacerbations rather than dyspnea. Is that correct?
Yep.
Okay, got it.
No, sorry, ICS is more for exacerbations.
Yep.
Not dyspnea. Yeah.
Correct. Okay. So the next question is, which patients do we refer for pulmonary rehab? The guidelines seem quite vague about it. It says that there is benefit. So practically, who should we be referring?
So basically, the ideal situation is most of them actually should be referred post exacerbation, because that's generally where a lot of benefit happens, where they reduce, they get better symptom control, their effort tolerance gets better, and they come to hospital less. There are certain contraindications like severe pulmonary hypertension and like. So pulmonary hypertension is a multidisciplinary modality. Okay, where it teaches you nutrition, smoking cessation, breathing techniques like pursed lip breathing, and some physio exercises. These are all intended in a multimodality method to actually help to improve the above. Okay.
So based on this, anyone from B to D should be referred for pulmonary rehab. Is that correct?
Okay, there is certain okay, by and large, most majority should be referred for pulmonary rehab. But if let's say you don't have a leg, or let's say you've got BKA, or you are already at the start, you are already debilitated, you can't walk, all these patients also come refer for pulmonary rehab.
So you take into account some of these practical challenges.
Yeah. Some of the comorbidities, etc.
Okay. The next question is about LTOT. I think you've told us about the indications that's stated on this slide. These patients, how long do they need to be on LTOT for in terms of
16 hours.
16 hours a day.
16 hours at least in order for it to show the benefit. So it was done by a 1980s paper called the NOT trial that needed them to have sufficient, the old LTOT should be at least 16 hours. In fact, actually this has been reiterated in the BTS guidelines in 2016, I think.
Okay. Yeah. And is there anything else we need to counsel about or take note of for LTOT?
Make sure you just don't smoke, because if not, it can explode in your face.
Okay. Thank you. Next is about when and how do we start home, and you mentioned Nocturnal NIV in particular. So which group of, is this the cut? So the cutoff I see on the guidelines is 53 mmHg like you mentioned. So this is based on must it be an outpatient kind of ABG, or in a patient who comes in and there is some evidence of decom type 2 failure, this is adequate grounds to start them on home NIV? Okay,
so the studies, so if you look at the studies over time, initially this was not recommended. The reason why these subsequent studies actually show some more benefits, because if you think about it, most of these patients will be discovered to have decompensated chronic type 2 respiratory failure while inpatient, they have just been admitted, and post-discharge, their PCO2 may remain high, and therefore they give nocturnal NIV. However, it is important to realize that after the recent exacerbations, their CO2 may remain high for a while. It will take a bit of time for them to normalize. So the papers actually will suggest that you give them a trial or maybe about 2-3 months and repeat the ABG in the outpatient setting. That's how the guidelines went. And then you reassess and see if they remain persistently hypercapnic. If they are, then yes, you can consider starting nocturnal NIV.
Does this apply for the LTOT cut-off also for the oxygen? Because I noticed that those levels, when they're inpatient and exacerbating, it may be transiently lower. Do you use an outpatient reading usually?
No. Usually, actually, outpatient, you don't really book them so much. So then we go by SPO2 in the outpatient setting.
So we can look at the outpatient SPO2 rather than...
that's for LTOT.
Okay,
yeah.
Will do. And I guess this question about, because I understand that there are some surgical or interventional treatments for COPD, which of these patients, if let's say this patient is not managed by a respiratory physician, should be referred for consideration of such therapy?
Sorry, I don't understand your question. As in, who should we be referring? I see. So, so basically, what's the intent of the surgery? Okay, so there has been this, the purpose of this surgery or endoscopic interventions, the intention is actually to help to remove all these bullae and the upper lobe emphysematous changes, so that it actually helps to bring the length tension ratio of the muscles back to a more ideal situation, so that you can help breathe better. It helps to improve effort tolerance. So over time, and when we talk about surgery, they have done something called the NET trial. Okay, and there are certain criteria that needs to be fulfilled that before you can actually go ahead with potential surgery. Okay, and predominantly there must be upper lobe emphysematous changes. So it means it must not be homogeneous. Not means the emphysema should not be throughout the entire lung fields. Then subsequently, you also need to look at the FEV1 and the DLCOs and see whether they are more or less than 20%, because that will also determine whether they are a good candidate for surgery. Endoscopic interventions also applies the same principle, but that one requires some very specialized assessment, and simply because endoscopic LVRS or lung volume reduction procedures as this, while applies the same principle, actually targets a specific section, and that still remains in studies, because there's something called collateral ventilation, where if you block off one segment of the lung, it can still be supplied by other segments that you cannot see, because there are distal airways that may go to those areas. So those require very specialized assessment, and that one you should refer to the interventional pulmonologist for review.
So generally, these patients are very symptomatic by optimizing your medical therapy.
So like I said, there is a certain set of criteria to before you actually go ahead with that.
Okay, thank you.
So
So sorry. So the next question is, as these patients progress from A to B to C to D, my question is, what exactly does the trajectory of COPD patients look like? Because in, let's say, we have an idea when it comes to, let's say, the equivalent like CKD, when you push ESRF, we know that without dialysis, the prognosis is not good. Patients with COPD,
so maybe I will take a step back first. Okay, so you need to optimize treatment. With all the issues, and then you assess their symptomology. The role of endoscopic intervention is still not very widely practiced in Singapore. In terms of LVRS, like I said, it requires a specific set of data, such as looking at where the emphysematous changes are, etc. And if all these fail and they remain very symptomatic, and of course you want to look at their comorbidities, their overall functional status, and therefore you engage them in advanced care planning. So I don't think there is a situation where it is too late. But generally, most of us actually start ACP assessment when they are more advanced, or they have multiple comorbidities, or they are very symptomatic.
Okay.
Yeah.
And in terms of the trajectory, in terms of how it looks like when they are gold D, is there like a ballpark figure as to what is the likelihood of mortality in that period thereafter?
Sorry, can you repeat the question again? Couldn't hear
Sorry,
you.
yeah. So in terms of trajectory, right? So when patients hit gold D for COPD, is the mortality rate extremely high in those instances already, or many of them can still go on for many years?
They can go for years still. So at Gold D, when you reach Gold D, when you give the treatment, the treatment, it does not mean that they don't improve.
Okay.
So it's a multidisciplinary assessment. It's not just because it's Gold D, therefore he will deteriorate over the next 1-2 years. No, it's not. It's slightly different. Yeah.
Okay. And in your experience, are there indications for palliative consult for patients with COPD?
Oh, definitely. When they're very symptomatic, despite adequate treatment, if there are concurrent comorbidities, a lot of them may have concurrent cancers, maybe early stage, but you cannot intervene. Yeah, there are quite a few of these roles for formal palliative consult. It's a holistic assessment of the patient and not just with COPD alone.
Yep, got it. Thank you. Okay, the next question is about acute treatment. Are there any specific antibiotic considerations for COPD in general compared to a normal COPD?
So usually we will think about what the microbiology of cases, the microbiology associated with COPD exacerbations. Up to 50% are due to virus, which most of them, there's nothing very much you can do except for symptomatic treatment. If it's bacteria, usually the common ones are strep, haemophilus, morozella, and for those you want to give antibiotics to target these bacteria. So you can give beta-lactams as a first line. Yep. I know a lot of people like to give macrolides because but atypicals usually a bit less common unless they're concomitant pneumonia, then you may consider. The role of macrolides long-term in COPD is controversial, although there appears to be some role as it helps to improve symptoms. It does improve symptoms and reduce exacerbations.
So that's in terms of like using azithromycin as a regular medication, correct? Yeah. Okay. But that one is still normally administered more by the respiratory physicians rather than something that you recommend routinely.
Try not, let us see and assess. Sure. Because it's not a common thing and not everyone believes in it.
Okay, thank you. Okay, I think the last part of this talk, we would like to talk about respiratory support in the acute setting. So O2 therapy, high flow, and NIV. Maybe the corresponding questions are stated here. The first question would be just oxygen therapy. Do we aim 88 to 92 for all COPD patients or only in patients with chronic type 2 respiratory failure?
Only with chronic type 2.
Okay.
Only with chronic type
2. The second question is there a role for high flow for COPD patients?
Outside of clinical trials, we should not be using HFNC for now. There are some trials that suggest that there may be some that physiologically it helps, but it has not been proven in hard outcomes.
Okay. And the last question is NIV. We know that there is a definitive role for NIV in terms of patients with type 2, decom type 2 failure especially. What about COPD patients who come in with pure type 1 respiratory failure? Is there any role for NIV?
Usually when they come in extremely breathless, usually they are already decompensated type 2. So usually, yes, so NIV is a class 1 evidence for decompensated type 2 exacerbations. To answer your question whether type 1, you can use NIV as a trial. It's not a problem. But usually we don't.
Sure.
Usually we don't. You will try to give nasal prongs oxygen and we see how it goes, because usually if they have type 1 respiratory failure, it is not usually due to the COPD exacerbation.
Understand. Okay, so most of these instances it's decom type 2 and that's where the NIV benefit would be the most.
Yeah, yes.
Okay. So back to the last question, what were your take-home points for COPD for residents?
Number 1, inhaler choices. I'll re-emphasize the 5 points: the purpose, the type of device, the patient's comorbidities, the finances, and understanding.
Yep.
The second is that the adjuncts to COPD treatment, pulmonary rehab, LTOT, NIV, are relatively straightforward.
Okay.
The purpose of surgery, there are certain set of criteria which I have not elaborated here. But if you want, the trial is called the NETT trial. Okay. And I think the second point about endoscopic interventions, not very widely practiced at the moment, is still, but it has been, it is starting to become popular, and people are starting to try out in special subgroup, specifically selected group of patients.
Okay.
The last point I will give is that in regards to exacerbations, you do need to recognize the standard principles, okay? When to use NIV in decompensated type 2 respiratory failure, not in type 1 respiratory failure, okay? In chronic compensated type 2 respiratory failure, you don't need to use NIV.
Okay.
It must be decompensated, okay? And you are right when you say ventricular mask is safer than nasal prongs, because the underlying mechanism of how oxygen is delivered via nasal prongs and ventricular mask to achieve the saturation level that you desire.
Got it. Okay. Thank you much. Thank you very much, Dr. Andrew. I think the discussion has been really, really helpful, and I think likewise the residents would find it very useful. Thanks for your time today.